Okay, so we just use all of these as examples and sort of general principles. We did manage to cover our thyroid disorders and parathyroid disorders. So we'll go into the rest of our thyroid. Let me see if my laser, oh, it's back. Hooray, that's exciting. So basic concepts are that hypersecretion is going to lead to hyperfunction. If you release more of a hormone, your body will have more of a response to that hormone. Despite any regulation of receptors that may occur, it's probably not going to be enough to compensate. Likewise, hyposecretion is going to lead to hypofunction. And if you have a tissue resistance, if the cells are non-responsive, then that's going to appear as a hypofunction disorder. It's going to be similar in nature to a hyposecretion disorder. The difference is that it's the receptors, not the gland. For our hypersecretion disorders, we're actually going to see very many more hyposecretion disorders. It's much easier to simply break a gland and have it not work. For a hypersecretion disorder, in all likelihood, it's going to be a secreting tumor. Another cause would be an autoimmune disease. One of the reasons autoimmune diseases may be causing hypersecretion is if those cells are actually storing that hormone, and when you destroy it, they just release their products. Excessive stimulation by trophic signals, so that just means it's in a cascade and something secondary or tertiary is overstimulating it. Hyposecretion could be failure of the glandular tissue, congenital absence of the gland, that would be embryology, if the embryo didn't form that gland for some reason. Autoimmune destruction, and yes, autoimmune goes under both. Autoimmune could cause the release of cellular products as it destroys it, and then either short-term or long-term, it can just destroy all of those cells producing that hormone, and then you end up with a hyposecretion disorder. One way or the other. Another is going to be iatrogenic. What's iatrogenic? We caused it. Medical intervention caused it. So surgical removal of the gland. Let's say you started with a secreting tumor and we decided to remove that gland because it's a tumor. Now you're going to end up with a hyposecretion disorder. Sometimes, not universally, but sometimes it's better to deal with a hyposecretion disorder and simply replace the hormones than it is to deal with a hypersecretion disorder. Not always, but sometimes. And then lack of normal trophic signals, again, secondary or tertiary pituitary hypothalamus problems. It's not sending signals to it. And of course, that will lead to hyporesponsiveness. The target tissue will not respond, or tissue resistance, there's no receptor for it. Any questions there? And this is sort of the same idea. Etiology can be congenital, autoimmune, neoplastic. Remember that not all of our hormones come from dedicated endocrine glands. Some of our hormones come from other organs, like your kidneys. Your kidneys release erythropoietin. Get to you in a second. What's the job of erythropoietin? To initiate the synthesis of red blood cells. So if you had a kidney disorder, your kidneys are destroyed, they're not releasing PO. So what's the outcome of that going to be? Anemia. Absolutely. Okay, what's your question? Would compensate, right? It would try to compensate. We should assume that if it's secreting too much, you're going to have an elevated response. Would they ever be benign or a benign tumor to help your body just feel normal? So if it was benign, would they just make it? If it was a benign secreting tumor, it probably depends on the effect and what hormone. So for example, let's say it was a secreting tumor of the adrenal medulla and you have elevated norepinephrine and epinephrine. That's going to cause all kinds of problems. You want that removed. There's no problem with not having epinephrine and norepinephrine, frankly. We can get rid of that and we'll be fine. But there are others, I can imagine that hypersecretion may not have as big of an impact. I've never heard of that. Doesn't mean it doesn't exist. And is it kind of like with the hormones in your body, if you will just get back into homeostasis? If you remove the tumor, if you removed part of the gland, you could probably get back to homeostasis. If you remove the entire gland, again, it depends on the effect of that tumor or the effect of that gland in the first place. So again, if you completely remove the adrenal medulla, you're probably taking the adrenal cortex with it, and those adrenal cortex hormones have some importance to you. So you would still end up with a hyposecretion disorder of adrenal cortex hormones that we'll get to in a bit. Okay, so functional disorders mean an organ failed. That organ had a function in the endocrine system. It released hormones as well as its primary purpose. So for example, your kidneys fail, you have anemia because you're not releasing EPO. Heart failure, your heart releases atrial natriuretic peptide. Now your blood pressure regulation is off, in addition to all the other blood pressure problems you're going to have from heart failure, as if heart failure wasn't enough. Liver disease, liver has a number of endocrine functions, so on and so forth. Those functional disorders can also cause endocrine disorders. So again, if it manifests as an endocrine disorder, but it's an organ, that would still be considered secondary. And then again, tissue resistance is when target tissue fails to respond, and that would be mostly about the receptors. And we've already covered iatrogenic. It means we caused it. We could also be destroying glands because of chemotherapy, radiation therapy, or because we removed the gland. Probably we removed the gland because of a hypersecretion disorder. For most of our hormonal disorders, we have replacement hormones. Absolutely. Yeah, our replacement hormone protocols aren't always perfect. Everybody's individual hormone levels are going to be very unique, and tweaking them to get the right hormone levels for an individual is going to take some time and be a challenge.
Why is it that before hysterectomies they don't take a baseline of the person's hormones so they would know?
That would be smart. I don't know.
How do you know that they don't?
Because they don't. My mom got a total hysterectomy, and I mean, she had way too much estrogen. She was aggressive for a while, and then she had way too much estrogen. She was weepy. Like it took years to get her back to where she was supposed to be. Yeah, they like lose it a little bit.
So if this is not audible, the question is, why don't they take baseline hormone levels before hysterectomies? Have no idea. They probably should. Good Karen Riley question. Treatment for endocrine hyperfunction often involves removal or destruction of glandular tissue. That's actually, again, I mentioned my partner was once diagnosed with Graves' disease. His options were he could have had, you can like drink this radioactive thing that's going to kill your thyroid gland. That's one option. I know. Or have it surgically removed. Yeah, and he's like, I don't like either of those plans. So we waited it out, and his levels are fine. Yeah, it's something with, remember your thyroid gland likes iodine. Iodine's going to bind to your thyroid for proper thyroid functioning. So they bind this radioactive isotope to the iodine, and you drink it, and then it destroys your thyroid.
What's that going to do to like your urinary tract and stuff?
Probably something terrible.
That's what I was thinking.
Yeah. I know. And I could be wrong about the clinical stuff. This is through a non-clinical person that I'm learning this. So it's true. Yeah. Yeah. Oh yeah, iodine's itself is good. It's the radioactive stuff attached to it that's dangerous. All right, we did primary versus secondary. Again, the clinical manifestations are going to appear the same. That's why we have this differentiation of primary versus secondary. And we did that too. So we'll move on to our specific disorders, starting with growth hormone. What releases growth hormone? The anterior pituitary. We do need to differentiate anterior versus posterior pituitary, right? Because anterior is glandular, posterior is nervous tissue. They have different roles, different sets of hormones that they release in different targets. So growth hormone from the anterior pituitary, it is released in response to growth hormone releasing hormone. GHRH is actually how I learned that. Primary target organ is the liver, and this is about growth, just like it says on the label. The target tissues are not just the liver for glucose metabolism, but also your bones, your muscles, your fat, things like that. So you can have growth hormone problems throughout life. You can have growth hormone problems from the time you're born, or you can develop growth hormone problems later in life. The causes are multifactorial, yet again, because we have a cascade of events. We have this being an anterior pituitary, but released because of the hypothalamus. Therefore, if you had a midline brain tumor, or you'd had some kind of treatment for brain tumors, or some kind of trauma to the sella turcica. There's a reason I made you learn sella turcica. It's because it holds at the pituitary gland. It's pretty deep in the skull, right? So it's going to take a pretty severe trauma to break that, but it can be done. Those would cause growth hormone deficiencies in all likelihood. So growth below third percentile, hypoglycemia, because we are talking about glucose metabolism, thin hair, poor nail growth, greater fat with decreased muscle mass, delayed bone formation, and delayed puberty. This would be called pituitary dwarfism. There's different ways to be short in stature. There's different forms of being a little person. This is specifically pituitary dwarfism, which is different from many other forms of being short in stature. Yes?
Is that common in America, or do they figure it out pretty quickly?
I don't know. I've not heard of it being terribly common. I don't know the percentages.
It seems like when you go to like your model child visits, they always put you in a percentile, so you kind of know if something was wrong.
Yeah, I'm sure that's part of what the percentile growth is for. I don't know how quickly we'll catch it and what there is to do about it if we catch it. Probably replacement growth hormone.
Right.
I have heard of people getting growth hormone injections for more superficial causes than that. It makes you lose weight, right? Yeah.
There was something about like Peyton Manning having it delivered to his house, and his wife was like, I just want my face to be pretty.
I've heard of that. I've heard of almost a conspiracy theory of all the celebrities look super young because they're all on growth hormone injections. But what we're about to see is that too much growth hormone is also very bad. The opposite of that, if you had lifelong overabundant growth hormone, would be gigantism. So lifelong. So again, gigantism, pituitary gigantism would be something where the growth hormone excess would start from childhood before the epiphyseal plate closes. So the growth hormone targeting that epiphyseal plate and causing more growth of bones lengthwise, yes?
How do you giant people like the huge NBA players? Like, how do you decide like it's this versus you're just a giant human?
Growth hormone levels would be a good way to differentiate that. Yep. The other option is if you develop excess growth hormone in adulthood, and at that point your epiphyseal plates are closed, you can't grow more in stature, but you can still have tissue that grows, your fat distribution can still change, bony deposition can still change, and we call that acromegaly. And there's acromegaly. So there she is before onset of her growth hormone disorder, and there she is a few years later. And again, we can withdraw our growth hormone, but some growth has occurred. I'm not sure how reversible that is. We've kind of already covered the general thyroid hormone disorders, how T3 and T4 are going to respond in our negative feedback loop, but let's look at the actual physiology of it. The role of our thyroid hormones is to regulate your metabolism. And again, metabolism is a cellular level activity. That means we're going to break down certain things and we're going to build them up into other things, right? We're going to take the food we eat, the nutrition that we take in, and we're going to build them into components for the cell. That's metabolism. So your thyroid hormones are going to regulate your metabolic rate. Oh, I ate food, therefore I have building blocks, therefore I will build things for the cell in response to thyroid hormone. If a person has hypothyroidism, they may have very poor utilization of the nutrition that they receive. So there's congenital and acquired forms of hypothyroidism. Most of these will be primary. We use this as our sort of example for that cascade, but most cases of hypothyroidism are primary to the thyroid gland itself. There is a congenital form called cretinism. It's probably pretty politically incorrect, but what can we do? Due to thyroid dysgenesis, which just means the thyroid gland did not develop. And then secondary would be associated with head-brain conditions, because that would be the pituitary gland. Clinically, what you're going to see is a number of things. Let's look at it. Decreased basal metabolic rate. That's going to lead to weakness, lethargy, cold intolerance. Possibly bradycardia. They're going to have a low heart rate. Their pulse pressure is going to be narrow, mild, moderate weight gain. The thyroid may be enlarged. We call that goiter. This is a goiter. It was actually really common in the Great Depression when people didn't have access to iodine-rich foods. Things from the ocean are very iodine-rich. If you're living in the Dust Bowl, you're probably not getting the daily catch in Kansas. And that's when they added iodine to table salt, is to prevent that from happening to the general population. They may even be losing their eyebrows. The hair and skin dries out, and especially the lateral eyebrows can be lost, and menstrual irregularity can occur. Now, again, you've got your acquired hypothyroidism. It's also possible for Hashimoto's. You're going to see Hashimoto's twice. You're going to see Hashimoto's under hypothyroidism. You're also going to see Hashimoto's under hyperthyroidism. And I want to be careful here because everybody's Hashimoto's journey is different. But generally, the reason that can go under both is that thyroid hormone is being continuously produced in the thyroid gland and stored in the thyroid gland. If you remember thyroid gland histology, you have colloid. You guys remember the little lakes of colloid in our thyroid gland histology? That's stored thyroid hormone. So let's say you have an autoimmune condition attacking the thyroid gland. You start killing all of the cells that are producing thyroid hormone. That's step one. Now, this little lake has no keepers. Your lakes of thyroid hormone are just going to be released into your body without any kind of regulation. So at first, it's going to appear as a hyperfunction disorder. Hyperthyroidism would, hypothetically at least, come first. With me so far? Eventually, you run out of these lakes, and your immune system has destroyed all of your thyroid hormone secreting cells. All of your follicular cells are dead. Now, it's going to manifest as hypothyroid. So that's why it's under both. Yes?
Okay, let me make sure I got it right. So the thyroid hormone is being continuously produced and stored in those pools, and then if an autoimmune disease or anything affects the thyroid, then the lake is released, which is the hyperthyroidism, that the lake dries up. It's hypothyroid.
Exactly. Yep, once those cells are gone, they're gone. Now it's kind of an epithelial tissue. There may be some regenerative capacity, but it's an autoimmune condition. Your immune system's going to keep attacking it. So that's Hashimoto's. Again, you can have it iatrogenically, surgical removal of thyroid tissue. For example, Graves' disease. Let's get rid of the thyroid gland. Now you've got hypothyroidism. There's also iodine deficiency, and that's what we were talking about with the Great Depression. If you're getting certain like sea salts and kosher salts instead of regular old table salt, some of those are not iodized. Usually in the modern American diet, we're fine for salt. Everybody's salting iodine on everything. You don't need to worry about it. But if you're like one of these like organic purists who would never put, Morton's table salt into your body and you cook everything, and you're not getting seafood and other things that are rich in iodine, then there is that capacity to lack iodine and develop iodine deficiency leading to hypothyroidism. That's a possibility. It's a rare possibility. You probably won't see it. But it's a hypothetical. That's the issue when we start going, oh, I only want to use the Himalayan sea salt. If you're going to have that attitude and not put these things in your body because iodine's a chemical, you're forgetting some very important physiology, or you never learned it in the first place in all likelihood. Okay, so don't get goiters. That's what that's all about. Hyperthyroidism is going to be the opposite. There's Hashimoto's thyroiditis again, and it's the release of preformed T4, T3. T4 usually comes before T3. It's a metabolic pathway where T4 is transformed into T3. Your thyroid is mostly creating the T4 and metabolizing it to T3 in the liver. I'm not going to have you responsible for that pathway, just explaining it. The other one, primary disorder, would be Graves' disease, which is generally considered autoimmune. There's another name for Graves' disease. It's called diffuse toxic thyroid. And in this disorder, in Graves' disease, when we do imaging on the thyroid gland, there will be extra thyroid gland in ectopic sites. Goiter. Yeah, so yeah, we said goiter was hypothyroidism, but you can also have an enlarged thyroid gland with ectopic sites, and that's why we still call it goiter. In fact, we're going to use the word goiter in a few different ways, and some of them don't make a ton of sense. We're just going to roll with it. And again, you can still have a secondary disorder related to stimulation of TSH receptors from too much TSH being released by the pituitary. Here's another weird thing that we call goiter. This is exophthalmos. Another phrase for that is ophthalmic goiter. Yeah, I know, it doesn't make a ton of sense. Now, this is actually a different pathway. What's happening with the bulging eyes is inflammation of the fat pad behind the eye. And this can last for years if it manifests in Graves' disease. And technically, there's a surgical intervention for it, but it's not always utilized. And yeah, the thyroid hormones need to be normal for several years before it returns. Yep. Yeah. So exophthalmos, and you may see it listed as ophthalmic goiter, which is a weird one. But it's not actually specifically the overevent of thyroid. It's a pathway that leads to inflammation of that fat pad. It's poorly understood too. I looked into this because I was worried about my partner getting this because he was refusing treatment for a while. Yeah, I was like, dude, you got to be on your methimazole is what they put them on, and he was just not on it, jerk. Anyway, now hyperthyroidism, it sounds great. My metabolism's really fast. I can eat all the rice I want. Ha! And all the pasta and all the bread, which is what he does, and it's not fair. But if in the more severe forms, if he was in that clinical degree of having overabundant thyroid hormones, it does become a problem that is very health threatening. The issue is you keep metabolizing. And your metabolism and your metabolic rate has nothing to do with the food you consume. So let's say you don't consume enough calories for your metabolic rate, you're going to start breaking down yourself. You're going to start breaking down skeletal muscle, cardiac muscle, your own self. So people with hyperthyroidism that go untreated are at risk for developing, for example, a dilated cardiomyopathy, because they break down their heart muscle for metabolism. Yeah, and it's serious. So it's scary. And the thing is, people with hyperthyroidism, they may feel like they've got good energy, they are losing weight. Our society puts a lot of pressure on people to be thin. They feel good about themselves. It's actually much harder to treat somebody with hyperthyroidism and convince them to take medication. Case in point, my partner was not taking medication. And again, I was just lucky that he was in subclinical levels, right? So yeah, so aside from the feeling energetic for some people, feeling like their weight loss is good, there can be some uncomfortable side effects, or I should say signs and symptoms related to it. Elevated heart rate, anxiety, depression can go with this. Digestive changes, diarrhea, for example. And their appetite is probably going to be pretty high. Dietary intake is probably going to be pretty high despite their weight and appearance. In women, that can lead to amenorrhea and scant menses. Yeah, absolutely. What's that? I'm not entirely sure. Probably just the anxiety leading to it. This is one of those things that I just have personal experience with, so I'm like, depression. Gonna go with that. It's real. Yeah. Okay. Any questions about the thyroid? Okay. Now, back in our endocrine lecture, we talked about the adrenal cortex versus the adrenal medulla. You can have disorders just of the adrenal cortex. You can have disorders just of the adrenal medulla. That's why we switched that out. That's why those were separate concepts. So we'll start with the adrenal cortex. Does anybody remember the nifty mnemonic device for remembering what the adrenal cortex does? It's a good one. So this one takes care of salts, this one takes care of sugars, this one is sex. Salt, sugar, sex. The deeper you go, the better it gets. Yeah. So glucocorticoids have an impact on blood sugar. They have an impact on inflammation, which means they have an impact on our stress response and our immune system. Cortisol is my favorite example of a glucocorticoid. And it is true that elevated cortisol for long periods of time is going to impact your immune system, decrease your immune reaction to things, because it's actually decreasing inflammation. So it's decreasing the white blood cells and their responsiveness. And changing your sugar metabolism. So yes, you are going to get fat deposition. We call it abdominal adiposity, fat deposition into the abdominal. Poor energy store utilization as part of that. Next up is mineral corticoids, such as aldosterone. And so that's salts. What salts are aldosterone going to do something to? What's that? Retaining sodium. But there's another one that comes into play here. How's it different from ADH? You've got antidiuretic hormone acting on kidney tubules. You have aldosterone acting on the distal convoluted tubule. Yeah, nicely done. Excretion of potassium. So while you're retaining sodium and therefore retaining water, you are excreting potassium. This is mineral corticoids. These are minerals. Sodium and potassium are minerals. So aldosterone, secreted by the adrenal cortex. And then androgens, such as testosterone and estrogen. So yeah, we have gonads releasing testosterone and estrogen. But even without gonads, we still have this other source. And both men and women produce both testosterone and estrogen. There's no such thing, by the way, as a female hormone and a male hormone. That's been in the news lately. Did you guys hear about the athlete, female athlete with high testosterone levels?
What did they say?
They won't let her compete because her natural testosterone level is too high. They think she's too mannish. And the way it's being reported is that she has too many male hormones. And there's no such thing as a male hormone. Both men and women produce estrogen and testosterone, and everybody's levels are unique. She is not an intersex or non-binary individual.
How do they let something?
Because the New Science's reporting is very poor.
That, like, she doesn't.
Where's she from? Cameroon?
I don't know anything about her. South Africa.
She's a beast at the point.
I mean, like, I'm just better than you.
Yeah. It's a natural physiological advantage that she has, and these things, these competitions are for what is your skill level,
Right.
not what is your physiology.
They used to say, like when Jackie Robinson won the play, they used to say black people have longer heel bones.
Right.
So they'll be better at baseball, which
Right.
is not true.
Yeah, I mean, there's all kinds of institutional sexism and racism at play in that decision. So that's why I'm clarifying. There's no such thing as a male hormone. There's no such thing as a female hormone. We all have testosterone. We all have estrogen. Our levels are unique to each of us. And that's it. That's all there is. Okay. So that was a review. So let's start looking at what happens when it's too high or too low. Adrenocortical insufficiency. Now, there's a couple of ways to get Addison's. There's Addison's disease. There's also something called an Addisonian crisis, which is a little bit different. So if you have an idiopathic or autoimmune form of adrenocortical insufficiency, we call that Addison's disease. And the core part of the problem is that the cortisol is insufficient. Now, I've got a picture of Kennedy there because it's thought that Robert F. Kennedy? John F. Kennedy? Oh my gosh, I can't remember his. Kennedy had Addison's disease, at least as far as we can understand. Do you have a question, or you just have your hand?
I'm just listening to my hand.
Okay, no worries. You can do what you want. I just want to make sure I'm not missing stuff. Okay, so Addison's, this insufficiency leads to weight loss, anorexia in the sense of just not eating, salt wasting, weakness, malaise, apathy, electrolyte disturbances, which you now know electrolyte disturbances can be very serious. Hyperpigmentation, appearing a little bit tan, sounds like a good thing. probably a bad time. Hypoglycemia, hyperkalemia, decreased vascular tone, reduced cardiac output, inadequate circulating blood volume, low blood pressure. It can lead to cardiovascular collapse. You can die of it, absolutely. Now again, that can be autoimmune, it could be iatrogenic. And then for Addisonian crisis, this one's pretty clinically relevant to you. These are steroids, right? Glucocorticoids, mineralocorticoids, you might have heard of corticosteroids as a phrase. So if somebody is on corticosteroids as a drug, and then they stop taking them all of a sudden, they can go into an Addisonian crisis. And that would be very sudden, so that can lead to circulatory collapse. So let's say they run out of medication, they can't call their doctor because it's a long weekend. That can happen really quickly. It's really bad. So yeah, acute withdrawal of corticosteroids due to periods of stress and trauma. Yeah.
Is that why, like, when they give you prednisone, it comes in like a pack, like a preset pack?
Probably, yeah.
Is it like slowly?
Yeah.
Yeah.
Yeah, that makes a lot of sense. Make sure that you're covered for your weekends and holidays, that you can always get in touch with your doctor. And there's a major socioeconomic thing there too. I feel like this program doesn't talk about the socioeconomic issues, does not have enough, but there is. Okay, the opposite would be hypercortisolism. Again, this is the adrenal cortex in general, but we're most clinically concerned about the cortisol. Cushing's disease and syndrome. Cushing's disease is probably going to be related to a pituitary hyperstimulation. Cushing's syndrome is any other reason for hypercortisolism. It could be a disease of the adrenal cortex. It could be related to ACTH secreting cells. What's ACTH? Nope, that's ACH. Adrenocorticotropic hormone, well done. And then, of course, tertiary hypothalamic dysfunction. Since we already established that pattern, hopefully that made sense. So again, ACTH is in the anterior pituitary. Cushing's involves abdominal adiposity, development of striae, which are stretch marks, fine hair, being prone to a ruddy complexion. Hirsutism means developing hair in places you previously did not have hair. Fragile skin. What else? That's all I got. And again, because this is hypercortisolism, we can perform surgery to remove the adrenal cortex, probably the adrenal gland, and thereby decrease our cortisol levels. So this was Cushing's disease, and then she had her adrenal cortex removed, and that was her face after. Her hair did get bigger. I don't think that's related to the Cushing's, but not necessarily.
Well, maybe if they fixed it, did fine hair before.
It's true. If this is her fine hair, which is still pretty spectacular. Yeah, that totally looks very 80s. Here's a great word. I think I've already used this one before. Pheochromocytoma. It's a great word. Pheochromocytoma. This is a secreting tumor of the adrenal medulla. What's your adrenal medulla release? That's adrenal cortex. It's the panic button. Epinephrine and norepinephrine. Yeah, it's right up there. So that helps. All right, this is the mini panic button. This is the panic brain in your abdominal cavity. So if you develop a pheochromocytoma, if you develop a secreting tumor of the adrenal medulla, you're releasing, we call this category the catecholamines. I absolutely want you to know the name catecholamine. Catecholamine is the category for norepinephrine and epinephrine. And I am going to use those phrases interchangeably. If I say catecholamines, you think epinephrine and norepinephrine. They mean the same thing. So now you've got a tumor of your adrenal medulla. It's releasing catecholamines all the time. How are you going to feel? You're going to feel wired. You're going to feel freaked out. You're going to feel like you're in fight or flight all of the time. I agree. So hypertension, headache, tachycardia, diaphoresis, tremor, nervousness, emotional lability. I wonder, right? It's like, oh, there's a bear chasing me, but I'm just sitting here. Pallor, fatigue, orthostatic hypotension, and a hypermetabolic state. Remember that while you're in fight or flight, you're going to be breaking down things for energy for use constantly because you got to run away from a bear. Okay? Yes.
To me, that sounds just like taking like ADHD medications.
Right.
Exactly. Is that affecting?
So ADHD medications, I actually did a guest lecture. You're going to see this in a couple of weeks. Back when we had a previous instructor for pharmacology, I did a guest lecture on psychopharmaceuticals, mechanisms of action of psychopharmaceuticals. So ADHD medications are in the, not methamphetamines, but they're in the amphetamines category. They're excitatory to the central nervous system. So I can imagine that's going to feel physically similar if you're exciting the CNS. Mechanism of action is going to be different. It's not adrenergic in nature. I want to say cholinergic, but I would have to check my notes on that. Acetylcholine does a lot of things, or glutaminergic in some cases, something like that. It's in my guest lecture. I left that guest lecture up. You probably won't need it. Ashley Watson does a fantastic job. But if you find for some reason you're not understanding the mechanism of actions of psychopharmaceuticals, feel free to give it a watch. It's still up there. It's just MOAs. It's not drug names. It's not specific anything because I'm not a clinician and I'm not qualified. I am qualified to talk about mechanisms of action and neuroscience. So that's what I focused on. And it helped a little bit back then when their instructor was a different person. It helped them like 2 questions on the ATI, which I only lectured for an hour, so I feel like that's proportional. Okay. Where are we at? Parathyroid gland, we kind of already did this, so we'll just skim through it. Parathyroid hormone is about calcium homeostasis. If you're hyperparathyroidism, then you're going to have problems, you're going to have low calcium. And again, this can be idiopathic, it can be genetic. There can be a parathyroid adenoma, that would be, again, a secreting tumor. Hyperplasia, again, that's still kind of talking about a tumor. And then chronic renal failure. Your kidneys are needed for vitamin D retention. So chronic renal failure can lead to hyperparathyroidism. You're going to have bone reabsorption and formation rates altered, changed, increased. So we're reabsorbing bone. And I did mention you can randomly deposit that calcium into inappropriate places. That's why you're still seeing the word formation there. Does that make sense? Hypercalcemic crisis, it's rare. It's a rare that this would cause a hypercalcemic crisis in humans. But yeah, it can happen. There we go. And then some malignant cells, not of the parathyroid hormone, but some malignant cells will release something similar to PTH and cause that more likely hypercalcemic crisis. Another thing about that calcium being in random places, maybe one of the places that calcium lands is your kidneys. And then you get kidney stones. Maybe you get osteoporosis. With that elevated calcium, maybe you're drinking a lot and peeing a lot to try to get rid of that calcium, just like you would in, say, diabetes mellitus when you have a lot of glucose around. When there's overabundant substance in the bloodstream, one physiological mechanism is going to be to drink a lot of water and pee out a lot of stuff, if your body can't otherwise get rid of it. Good? Good. And as you know, hypercalcemia is going to decrease neuromuscular excitability, and that's going to go with bradycardia, possibly a heart block. That can lead to cardiac arrest. Yes, you can die of it. Do a little bit more before break. Hypoparathyroidism could be idiopathic or autoimmune, could be secondary to parathyroid or thyroid surgery, maybe temporary, maybe permanent. Could be congenital or iatrogenic. Numbness, paresthesia, muscle cramp, spasms, fatigue, the things that we associate with low calcium, right? This is called Trousseau sign right here. I gave you Salt Bae because he's doing this little movement. So it's not quite right. You'd be doing this movement down here in response to pressure around the brachial area. Are you guys all familiar with Salt Bae? Do we want to watch the Salt Bae video just for fun? You've seen it too many times. We'll watch it over break. I'm sure it's copyrighted, so we'll not put it on our video. So Chvostek and Trousseau sign are about sort of a tetanic contraction in response to the pressures. And again, that's related to increased neuromuscular excitability. I'm not sure. I don't know what the numbers are. We can look it up if you want. All right. Antidiuretic hormone is released by the posterior pituitary. It acts on water balance, blood volume. It acts on the collecting ducts of the kidneys. Now, aldosterone did what specifically? Excretes potassium, retains sodium and therefore water. How's ADH different? It doesn't excrete potassium, so you have sodium reabsorption and therefore water reabsorption, specifically at the kidney tubules, right? Your kidney has a very salty medulla, so your water is going to go towards that in the presence of aquaporins, and that's what your ADH is doing for you, is putting those aquaporins in the plasma membrane. It does not excrete potassium. Do you guys see why I made you memorize the difference between aldosterone and ADH in the day, now that we've had our electrolyte disorders? Why that difference of potassium is a big deal, right? Absolutely. So ADH works on the collecting ducts. It increases membrane permeability with aquaporins. We reabsorb water, resulting in concentrated urine. We reabsorb as much water, stay hydrated, and the urine we get rid of is full of waste products, all the stuff we don't need. We keep what we do need, we get rid of what we don't. So one of the reasons we need to say diabetes mellitus when we're talking about diabetes that we culturally consider diabetes is that there's also this thing called diabetes insipidus, which has nothing to do with glucose. No glucose involved in this process. So diabetes insipidus is going to be related to antidiuretic hormone activity. It's probably related to damage of the hypothalamus because remember, ADH and oxytocin are produced in the hypothalamus but released by the posterior pituitary. So those neuron cell bodies are in the hypothalamus, they project the posterior pituitary, and then for whatever reason, they release that substance into the bloodstream. It was all one neuron, right? That's why we have a separation between anterior pituitary and posterior pituitary, because this is going to be about damage to the hypothalamus. When you have damage to the hypothalamus's ADH-producing cells because of an injury or a tumor or a procedure, it's going to dysregulate your water balance. You're going to be drinking a lot of water, and you're going to peeing a lot of very dilute water. So the water that you drink is not hydrating you. It is going straight through you. Yeah. So large diuresis of inappropriately dilute urine. There's also nephrogenic, and if it's not the hypothalamus, it's possible that it's the kidneys that are at fault for diabetes insipidus. Polyuria, polydipsia, low urine-specific gravity, which just means dilute, not a lot of concentration of waste products. Nocturia, peeing at night. Hypernatremia is a possibility here because you're not hydrating yourself. You're not getting rid of the waste products. You're not getting rid of the sodium. You're retaining the waste products. You're just getting rid of excess water, right?
That one's a little bit confusing because it makes it sound like it would be the opposite.
Right, you would expect to be well hydrated, but you are going to not have the antidiuretic hormone. You're going to be peeing it all out. You don't have the reabsorption. So you're poorly hydrated despite, yeah, no aquaporins, no hydration. Even though you look like this, you're not hydrated. And then the opposite, syndrome of inappropriate ADH. Maybe there's an ectopic tumor producing ADH. Some lung malignancies, weirdly enough, produce ADH. And let me see. So now you have excessive ADH. You have increased water reabsorption. Now you've got hyponatremia and increased plasma volume. So you have hyponatremia now. And this is why we already did the electrolyte balances. It keeps coming back. And that's as good a stopping point as any.